to Advent 1st and 15. Today is the 1st of April. I have the pleasure to have a guest speaker from Russia, Professor Sergey Karpischenko. Good morning, Professor Sergey.
Yeah, good morning. Good afternoon.
Yes, it depends on where you're connecting from. So today I've requested to Professor Karpischenko to have a talk on the ophthalmic complication of functional endoscopic sinus surgery, because as many of our colleagues know, during our normal procedure, during endoscopic sinus surgery, the limits of our fields are determined also by the orbit. So it's important to know what are the complications and how to manage those complications. So I will lead the torch to him. He will start with his presentation. Please do remind to ask all the question with the question and answer for those who's registered over here, and from the other YouTube and Facebook, please type your question at the end of his talk. Please go ahead with your presentation, Professor.
Yeah, thank you, Puya, for a kind introduction of my person. And first of all, I would like to say it's a great responsibility to speak about complications. Last months and years of his life, Professor Heinz Stamberger, he visited us in the last year of his life, and he started his presentations from words. Do we need to teach a new rhinologist for face surgery? It was semi-joke, because he means complications, mostly CSF leak, and of course ophthalmic complication. In some instances also internal carotid artery bleedings, but not in neurosurgical procedures. He means simple face, our basic procedures. Then someone trying to remove polyps and damaging serious structures and get severe complications, which is influence not only on patient but on all staff and surgeon personally. So of course, sometimes complications unpredictable, like our situation with coronavirus. We were living in normal life, European style. We were traveling a lot. We spoke a lot, shared with each other our experience. It was nice, interesting life, and it was complicated by disease. Now I think human society understands that breathing system is most hazardous and dangerous for human life and human civilization. So some complications, of course, unpredictable, but in most cases it can be prevented by careful CT scans, examination, discussion with the patient. Sometimes patient can explain much more than they think about. We are not listening patients. That's a very important position. So I designed this presentation as a new one for this session, for this our lecture and our discussion. So it's absolutely new. I don't know exactly what is details of my presentation. I will try to explain my experience and how to prevent this severe and not severe complication, how to predict. I'm working in face field close to 20 years, long time, around 1,000 procedures per year. And luckily, I have no really major complications in simple, basic face cases. That's why I can speak about how to prevent. My first point in this successful, I pray it will be successful in the future, but main point is not for beginners, for residents, because I little bit in post-Soviet time self-educated. So I was very careful and very slow then trying to open more and more sinuses. First several years I operated only inside nasal cavity with a laser or with hot instruments. After experience holding on instruments, I started to open sinuses, of course, after reading international tutorial books, because at that time it was not possible to travel a lot. My first proposal for residents not to be very fast. Listen your teacher. Then he said, like in Kung Fu Jedi's, you are ready. That means you are ready. Not to be fast, not be so fast, and don't press your teacher. He knows much better situation, and he is responsible mostly for complications. Now I'm presenting two units, two huge ENT units of Russia. It's ENT Institute. I am director of this huge single specialty institute, 206 ENT beds, only 1 year, but I'm a chairman of ENT department of Pavlov Medical University around 12 years, and all my ENT life belongs to this department. So most of experience from this Pavlov Medical University ENT department. How much time I have, Puya? Around 1 hour?
You have 30, 35 minutes maximum, so then we will have some minutes for the questions.
Not a lot, so I have to be fast because my preliminary words was a little bit long, but very important. I start with famous publications about unilateral blindness in cases of septoplasty. It's easy to find these publications in Google. You don't need a special search system. You just dial this topic in Google, and it gives full articles, full text articles. How it's happened? It was not fast procedure. Surgeon tried to remove spur in nasal floor, and they damaged optic nerve in posterior ethmoid or nodule cells or in sphenoid sinus. It's happened accidentally. Surgeon could be very experienced, but assistant second surgeon was not experienced. His strike with a hammer was too strong. Then you are operating as experienced surgeon. I recommend to have an experienced and a nicely instructed assistant who is beating or hitting, striking with a hammer in a very short distance, tuk 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 tuk, not like this, because it's very dangerous. If chisel holding is not enough, it can fall down inside ethmoids and sphenoid, and you see this terrible picture. I know this story from 2014. It was published in BNT. It was famous and unlucky story. Then 24 years, I may say, girl became blind after septal procedure without any sinuses. So that means everything possible in rhinosurgery, not only in FES, in open surgery, in our basic septal surgery, and during turbinoplasty. I will show you ophthalmic complication after turbinoplasty. This is another article. There's the same damaging of optic nerve in the apex of orbita. Terrible situation. What to do after transection of optic nerve? Almost nothing, only to prevent intracranial complications. That's it. And how to explain the patient what was happened? It was abnormal anatomy or something unexplainable. This story also, you know, complete removal of eyeball. It was published in JAMA Ophthalmology. Complete accidental eyeball and all orbital content in patient with nasal polyposis. As you see here, can you see arrow? Yeah.
Yes. Yes.
Not a lot of polyps. Normally pneumatized sphenoid sinus. I think it's not result of surgery, this pneumatization. It was not strictly indicated. Very important point of my talk is always follow real indications. If surgery is not strictly indicated, it leads much more often to complication. Surgeon was too fast for decision, I think, and you see only some opacification in the middle area of ethmoids. Assessment of computed tomography is one of the main points for such a case. They removed a lot of soft tissues, but opacification was not so serious. How to solve this? Only to make eyeball prosthesis, but you cannot recover vision loss in this case. Terrible situation, and how it's happened. Uh, they wrongly thought that orbital floor was floor of maxillary sinus. That is explanation. Other level, they worked inside orbita and thought they are in maxillary sinus. What is easier than maxillary sinus? Every one of us think nothing. Maxillary sinus is less risky than other sinuses. That is not truth. This is our common mistake. How to prevent this complication? Again, we return to assistant. On the left view, you see typical situation in many rhinological clinics and operating in many theaters in St. Petersburg and other cities. This is common mistake to close eyes. How assistant can observe orbita and how eyes and soft tissue in this area looks like. This is correct position. With it intubation or not doesn't matter. They could diagnose in such situation much earlier that they are inside orbita because of hemorrhage or orbital movement, artificial movement, and so on. Situation can be identified much earlier if eyes opened. Then I operate in under local and under general, all this like this. This is my recommendation. And if surgeon looking at the screen, assistant looking at the face of patient, anesthesiologist controlling blood pressure and other inhalation, artificial lung ventilation system and so on, saturation, and that's all. Another recommendation, then you are operating maxillary sinus under local, under general, use inferior meatus, not with temporary, use temporary approach. If it's not rhinological indication, you can operate without osteomiatal unit correction. On this CT, you can see implant inside maxillary sinus. Why do we need to improve risk of orbital damage via middle meatus? You can exclude any risk of orbital damage in such situation. Sometimes with the unilateral cysts, preparation of sinus to future implantation on something like that. And if you are beginner, also use inferior meatus. It's 100% less risky for orbital damage. How it looks in reality, this is of course record of one of my operations around 10 years ago. We use it commonly also in polyposis cases to check maxillary sinus floor. You see here procedure under local anesthesia. It's not painful. Orbita is out of view. You have no risks to damage also lacrimal pathways. It's not rhinological indication for surgery, so you must not damage orbita at all. And it's much better than anterior wall approach. It's also risky. Anterior wall approach also risky for orbita. Here, no, 0 level. And I close this inferior meatal window. That's it. End of procedure, and no blood supply in this area, which can lead to postoperative bleeding. No, outpatient procedure. If you are thinking about lacrimal pathways damage as ophthalmic also complication of this surgery, you see it far away from approach area. It can be interiorly from lacrimal pathways, posteriorly, or usually it's sublacrimal, because you are opening sinus down from these lacrimal pathways. You see here pipe of lacrimal pipe. It's nice, very nice. It's uh, wide pipe of lacrimal pathways, no risks. But I would like to show you, you can control this area completely, no risk of orbital damage. Now, classification. I'm not sure we need to read all these points. You know it nicely from books of many experts, this classification. We would like to speak mostly about prevention of complication. I will skip and you can read it later in the record of this presentation. But rate of ophthalmic complication you see here is too high. 2%, some authors gives up to 5% of complications in our common, widely spreaded FAST procedures. And I mean also endonasal procedures, not only with open surgery. There is some publication about risks with microdebrider. In case which I showed with eyeball removal, that was happened also because of shaver usage. With forceps, Blacksley forceps, it was almost impossible to damage so seriously patient's orbita, to remove all these soft tissues, because then you use Blacksley forceps, you can feel how rigid is this tissue. Polyps is different than you touch it in compare with orbital fat or muscles and so on. It's different not only then you look on this tissue, then you touch, you can also feel serious difference. During septoplasty, I spoke about this and what to do briefly. And then optic nerve transection, almost impossible to do something to recover vision in this patient. After damaging of optic nerve, you can diagnose it only after waking up the patient. So in any case, you lose time. If it's compressive orbital hematoma, you also around 40 minutes, around 1 hour, 1.5 hours, and then retina diet. So you can lose time during awakening the patient, transporting him to the patient's room. That's why I always ask patient after awakening in operative theater, I'm waiting myself, how you can see me, do you have double vision or something wrong with your eyes? I check each eye one by one, both eyes separately, not together, because after waking up, patient is a little bit without complete consciousness. Now about emphysema, a couple of words. I hope you can see this screen copy. A lot of air in soft tissues and destruction of bony walls of maxilla. Of course, it's not result of FAST procedure, but model of orbital emphysema is almost similar. It was a result of trauma. A few days ago, we got this patient. It was criminal situation. Someone beated him. It's zygomatic orbital trauma, zygomatic orbital fracture. But emphysema, then you damaging medial wall of orbita, almost the same. It can be compressive as orbital hematoma, and it's risky for vision function, or it can be not so dangerous. It's only air inside orbita. You need to observe and wait a little bit, but under strict visual control. You may copy these classifications of stages of orbital emphysema, but this is our tutorial book about orbital fractures. We wrote it together with this group of ophthalmologists of our university, and you see here Professor Nikolaenko and Astachov co-authors, and I'm co-author of 3 parts of this book belongs to orbital fractures. So the best model to analyze how to do, how to treat, how to manage medial wall fractures, it's part number 4. It's almost the same, and if we speak about endonasal damaging of medial wall, it's almost the copy of trap door fracture. Trap door is common for children. It's a limited defect of medial wall, sometimes during sneezing. It's very similar strategy with this type of accidental fracture and first procedure. Open approach is well known, and you may say it's old history. It's photos from Alfred Denker book tutorial. We have it in our museum and reading sometimes in German. I don't speak German, a joke, just photos. You may say it was possible long time ago, but no. This is patient from big city. Aggressive surgeons operated her, but not endoscopically. It was open approach with nasal polyposis, severe complication and severe double vision. Also cosmetical defects. It can be resolved, and this is view of our patient after surgery, but it was also open approach to reconstruct medial and upper wall of orbita. So indications for medial orbital wall reconstruction, it's also indications from this book about orbital fractures, but it's not completely the same after first procedures. After some first procedures, we can not necessary to close bony defects more than 2 centimeters. It was if it was a result of surgery. Now about predispositions for orbital damage. Absence of maxillary sinus, for example, and narrow ethmoids. But here you see a few months old child, and that is complicated. Inflammation from ethmoids, damage with infection orbita. So it's a different situation, but similar. We are spreading to orbita from via ethmoids or maxillary sinus, infection also spreading. So strategy almost the same. But then we are operating scheduled FES. We are operating patients without any problems with vision, vision function and orbita. Here we are trying to save patient from complications, situation legally and philosophically different, but approach almost the same. We don't need to forget about open approach in complicated cases. Then it's a small child. We can use open approach if we are nicely equipped and have a good experience. In all the children, we use endonasal approach to manage orbital complication of sinusitis. And here you see complete opening of lamina papyracea. This is it. And you see no damages during surgery. So you can control and you must control all structures. Don't operate in a bloody operating field. I always use then operating ethmoids, performing revision surgery. I always use image guidance system and of course my own impression. Then you are operating polyps and not sure about your position, stop surgery. That's it. It's not life hazardous pathology. Then you are operating typical nasal polyposis. Stop in time. It's better not to open all sinuses next time. Remove polyps from nasal cavity, open clearly understandable by you structures and stop. Not necessary always to be aggressive in posterior ethmoids and sphenoid sinus. That means you are more experienced surgeon than aggressive surgeon. More aggressive you are, more risks for ophthalmic complications. This is also ophthalmic complication before our surgery and next day after opening. No orbital hematoma, no eyelids hematoma, no vision problems. And this girl are happy after our wide opening of ethmoids. We published our experienced safetiness of endonasal procedures in children in laryngoscope, but printed issue dated by this year. It's a very new article in laryngoscope published by us. There is no difference in safetiness, but endonasal procedures in children less morbidity than open approach. Now, rare complication, but it's also possible. You see here problems in the area of lacrimal pathways. What was previous surgery? Septal procedure and turbinoplasty. It was done by somebody, I don't know the surgeon, but he damaged lacrimal pathways during wide elevation of mucosa, and he destructed lacrimal pathways. Very difficult situation. It's not risky for vision function, but in this area, he could also damage medial rectus muscle in anterior part. You see, but it's also a problem to solve tearing and epiphora symptom because it is a comparable situation, not the same patient because it's left side. You see, this is my hands, I opening lacrimal pathways and orbital fat inside. How to solve this? DCR is difficult. It's not possible to give a good prognosis for this patient. Of course, we use stents and so on, but orbital fat is blocking lacrimal drainage. This is already, we are introducing stent, but as you see, orbital fat looks completely different with the polyps. So it's time to stop. Or procedure, if it's situation, we imagine example of polyps removal, and you see tissue is different. Yellow polyps exist, I believe. Sometimes we see yellowish polyps, but it's also look different with, once again, orbital fat. It's not cadaveric section. Main problem is bleeding, and it's not covering completely. If you use active suction, always hold an endoscope near your instrument, near tip of your instrument. Also, if you use shaver, be close to the window of shaver, and you see it's not a polyps for sure. So if you are operating polyps, stop if you see this and check if necessary with intraoperative CT scans, for example. It's not easily available, but in our clinic for patients under local anesthesia, it's also available. This patient, after procedure, because we touched orbita or eyelid fat maybe, and some edema immediately after procedure. We used ice for 5-7 minutes, and in 20 minutes after procedure, she looks absolutely different. So ice is very helpful. Put it here, wait a little bit, a situation is changes. Also with orbital hematoma, it works. Don't forget about simple and old-fashioned procedures like ice. Now, a few words about predisposition. Changed anatomy during previous surgeries, ossification, osteitis, damaging of orbita by previous procedure, no anatomy, small maxillary sinus, for example, silent sinus syndrome. If you are going to maxilla here, you are easily damaging orbita. And this is not worst situation I ever seen. That's why in cases of silent sinus syndrome, I use mostly inferior meatus. You open like I showed before, maxillary sinus, and then you check this area from maxillary sinus and open it. Less risky because you can observe orbital wall from inferior meatus. If you use angle scopes, it's not difficult. Less risky for orbita. Predisposition for orbital damaging like this is also from experience of orbital damage. You see here in the area of left ethmoid some opacification, but it's not polyps, it's orbital fat inside. So situation is easy. No indication to remove these polyps. It's not a polyps. You can only damage orbita and remove some fat. It's easy to detect in this case. And if we compare with this situation, you cannot detect orbital fat inside these polyps. This is much risky situation. If there is some branches of orbita crossing ethmoids, you are in a high level of risk. And if it's situation like in the previous video, but with a total polyposis, much risky to damage orbita. If necessary, we use MRI. It can help to detect where is orbital fat spreading, or you need to use other mode of CT scans to see better bony walls, bony structures. It can help, but sometimes it's not enough informative. So in such a cases, always be careful. We have around 10 patients like this or worse every year. It's risky group. Now, anodid cells. This structure can be really different, and sometimes it looks like this. You see here like four sphenoid sinuses, but it's not four sphenoid sinuses. Uh, it's two sphenoids and two anodid cells, and optic nerve crossing sphenoid sinus. Luckily, no indications for surgery in this patient. Don't operate him. No indications for ethmoid opening, and luckily we can see these optic nerves and very uncommon and risky anatomy. You see here optic nerve crossing sinus. But if it's situation like this, with complete opacification of both anodid cells and sphenoid sinuses, you cannot see so nicely optic nerves. So don't be active laterally. It's only polyposis. It's not a tumor. Stop in this area. You can open sphenoid ethmoids in the medial part, but don't use aggressive instruments and don't be aggressive working in this area. Stop in time. This is a strategy of experienced surgeon. Um, Now, situations then we deal with small, very limited pathologies. You see here a small cyst on the optic nerve. This is from my own experience around 10 years ago. We operated this patient. He was suffering by progressive visual loss. That's why removal of this cyst was really indicated by experienced ophthalmologist. And you see here optic nerve and this cyst. I use only two scopes, 0 and 45 degrees, and it was long time ago. We were not so nicely equipped. I use circle knife and flamingo forceps. That's it. That's it. No any sophisticated instruments. It's forceps for maxillary sinus, our well-known flamingo. We removed it, and problem has gone. His vision was okay. We published this interesting case in BNT in 2017. You are interested in, you can read. It's free access on the website of Belgian ENT magazine. All articles is free. Now, similar case, also similar, very limited pathology on the orbital wall, on lamina papyracea. But it's symptomatic. You see here, it's very small, close to orbita, but it's separated by lamina papyracea. We also uh, made MRI. We detect this. And what is the indications? Patient described feeling of pressure in this area, and after this complaints, we made CT. Uh, she became suffering not after CT. We made CT after her explanation of her complaints. That's why we operated her. Be careful always with surgical procedure. Always keep operative area dry. You don't need sometimes to open widely all ethmoids to find this cyst. This is it. This is not so small if you use magnification, but control all surrounding tissues. Not life hazardous, but patient is suffering. We must not damage orbiter here if we know where is it. That's it. No complications and problem and complaints has gone after our surgery. Control operative field. If you don't understand where you are, stop. It's not life hazardous procedure. I repeat in this position because it's very important. Stop in time. And always use, if it's risky situation, any ethmoid surgery is risky situation. I always use image guidance, also like medical legal aspect. You make screenshots and collect it in your database, and if something happened, something unlucky, you can prove that you were right, you were in a right position. On another hand, you see huge pathology and bony. Previous was very small, but we could prevent damage of orbiter. Here, orbital wall already damaged by pathology, not by us, so we cannot prevent orbital damage here. And main symptom for this patient was orbital emphysema, accidental after blowing nose. So it's like combination of trauma and operative damage. Because of course we got here orbital hematoma, not compressive. I don't think we need to observe all procedure. And what was wrong here in my hands, it was long time ago also, I drilled out not enough. You see, we could damage also nostril, then removing this huge bony tumor. It's osteoma, of course, in young patient. So then removing osteoma from orbital wall, drill as more as possible until it's mobilized, becomes movable. And you see here orbital fat, it's also different. That was destruction area of orbital wall, but mostly by pathological process, by this huge osteoma. That was layer of osteoma, but no any damages back from eyeball in the area of optic nerve. Now this is fifth day after surgery. What is important for managing of this patient? Don't make decision only with yourself and with your ENT team. In multidisciplinary university, we are working in university, always ask ophthalmologist immediately examine vision function, movement of eyeballs, and other uh, symptoms by ophthalmologist. Very important observation by ophthalmologist during several days after such a complication as orbital hematoma. In this case, it was strategy only to wait and see. That was recommendation of ophthalmologist. Lateral cantotomy was not indicated in this case. Another situation, then destruction of orbital wall by osteoma combined with infected sinus. Then you open orbiter in patient with infected sinus, with blocked frontal sinus, you have risk of postoperative purulent inflammation or some infection complications from orbita. You see here very similar with previous case, orbita is distracted already and sinus infected. Periorbital tissue we use as orientation layer. We don't penetrate orbital periorbita to prevent fat prolapse into the operative field. And removing step by step using periorbita like analog navigation. We use, of course, electromagnetic navigation, but analog navigation is also important. We always compare result of image guidance system with our analog, our brain, our own navigation. So hematoma in this patient was not so severe like in previous case. We were more experienced at that time, but we used active antibiotics therapy to prevent inflammative complications in several days after surgery, because frontal sinus was filled with pus. It was not mucin, it was infected content. And how orbital fat looks in similar situation. This is it. We accidentally with a drill damaged periorbita, and fat become an obstacle to open frontal sinus. It's not just a complication, it's obstacle for endonasal removal of giant osteoma. So it's very important to detect in time. This is small damage periorbita, so don't be active more in this area, otherwise orbital fat can completely close your approach. So always fat can be detected in time, in the first stages of procedure. This patient, you see spontaneous resolution of orbital hematoma, and in 7 days, almost nothing, and we removed successfully. But it was happened because we were successful in time. Comparable situation, 2 weeks ago around, we operated this small osteoma. We were experienced enough in that time, made MRI, and at the end of procedure, we got 0 complication from orbita, but in 2 hours after surgery, after accidental sneezing, he got orbital hematoma. So be active then observing patient also after surgery. In operative theater, he was okay, he was fine, but in patient's room, in observation theater, he got orbital emphysema, but not compressive. And in 7 days, it's solved spontaneously under strict observation by ophthalmologist and by us, of course. I'm not sure we have more time.
We are a little bit late. We are a little bit late.
Yeah. So my conclusion, don't be aggressive and simple, our typical fast procedures. Don't be fast and don't be extremely aggressive. Stop in time. Thank you for your attention. And don't forget about 2021. I hope our Earth complication will stop.
Thank you for your presentation, Professor Karpischenko. And yes, I'm glad that you presented the World Congress of Rhinology, which is going to be held in St. Petersburg on July 2021. And exactly your point was perfectly done to pinpoint the importance of this COVID-19 pandemic thing going on, and we will hope that everything will going to be solved as soon as possible. First meeting is going to be interrupted probably for the ERS meeting. We're going to see what's going on. So before proceeding to the question, we have so many right now, so we have to take in consideration importances of few things. The first question is coming from in Egypt, and our colleagues is asking what's the name of the maneuver that you're using to palpate the orbit in cases of orbital damages.
You mean intraoperative?
Yes.
I just pressing on the eyeball. That's it, and you can see same movement like pulsating inside nasal cavity during endoscopy.
Okay.
We use this test intraoperatively common.
Okay. Okay.
Pressure on the eyeball.
It's important. Exactly what you said is important, as you during the operation you have to palpate the orbit to make sure that the content is going inside or is not going inside. The Stankiewicz maneuver, it's very important to avoid any of those previously reported damaging on the tissues. The question is coming from the audience is as one pupil is dilated and one is contracted. So the question is, was the patient with accidental sneezing and hematoma of the eye was responsive with both eyes?
You mean first patient?
It said as one pupil is dilated and one is contracted. I think the accidental sneezing patient, the last one.
Ah, yeah. We only think about it was sneezing because he was awaking already, and we moved him to from operative theater. He was fine, and then we checked him in 2 hours. He got black eye.
Okay.
It's only suspicion. It was sneezing, but sneezing can also damage orbita in children without any surgeries.
Okay. So another question.
Because pressure increasing very high during sneezing, and with blocked nose also.
Okay, so another question is in case of revision fast surgery for recurrent frontal mucocele, where we find prolapsed periorbital fat obstructing the access to the frontal recess, how to go about further with the surgery?
That was my last case. You see here, this is it. This case after, it's better to show.
Yes.
This case, revision surgery after removal of inverted papilloma years ago, and he returned to us. He is a sailor. He spent 3 years in the sea on the other continents, so he couldn't ask us to help him. That's it. That's it. This is this situation you asked about. This was blocked by soft tissues and little bit with orbital fat. It's passed from frontal sinus, and there was some orbital dislocation before surgery, before revision surgery, you see here. And then we opened this sinus as wide as possible. And due to other walls, which was intact in frontal sinus, we got this situation. You see the window. It's again a screen copy in the room. This is it. You can observe nice window to frontal sinus. In this area, orbital fat. And that is area of orbital destruction. Sometimes it's possible, but don't forget about external approach. Then you cannot manage endonasally, you can use open approach. It's also possible. Sometimes stents and so on, but here we don't use stents. This is window after our revision surgery and removal of mucopiocellae.
Okay, so another question is how often does the anterior ethmoid artery retracts into the orbit and cause hematoma and causes blindness?
In simple fast cases, it must not happen. Never with me in many, many years. Around 10,000 patients or more. with frontal sinus surgery. It's never happened with me, and I pray it will never happen.
The
But
question,
if
I
it
think that
happened, it's also area of responsibility of assistant,
Mhm.
because you are looking at the screen. Assistant must inform you.
Okay, so the question from this colleague is, I think it's that what's the percentage of the possibility during a procedure of fast surgery? How many percentage of time the anterior ethmoidal artery retracts into the orbit and will cause hematoma that will cause blindness?
No, that depends not on ethmoid artery. It depends on surgeon.
Hmm, okay, so
Yeah.
you mean
You
it's the,
detect. You must see operative field
yes,
on
sure.
the top tip of your instrument. You must see what are you cutting through, what are you touching. Everything can happen, but in this area, if we are speaking not about tumor surgery,
Yes,
you
sure.
must detect it.
Uh,
We are nicely equipped, most of us nicely equipped. We have a lot of books, we have a lot of teachers. Let's prevent.
that
I think for me, it's 0%.
would you
But it can happen in the world, of course.
yes, we were previously reporting the problematics of epistaxis, and previously the 2-3 panel was reporting the problematics of epistaxis. One of them is, of course, anterior ethmoidal artery bleeding, and usually, as you know, will happen because one, you might cut it, and or you using monopolar cautery, and that will happen because the retraction of the artery. As you reported, the onodi cell also, some of the problematic after ethmoidal artery retraction could lead to intraorbital hematoma, and that will lead to optic nerve compression. So is how would you manage orbital nerve optic nerve compression?
We must to decompress orbita.
Okay.
In our time is limited. Our ophthalmologists say you have only 40 minutes. PJ Wormal said you have 100 minutes. It's not a lot of time because you need to return your patient back to the operative theater. You need to detect this complication, understand what happened, and return patient after computed tomography to operative theater.
Okay.
You cannot promise good result after this severe complication. But you need to decompress orbita. If it's compressive hematoma, you need to make lateral cantotomy. If you detect it intraoperatively, if there is no external signs, you can detect, like during optic transaction.
Would you suggest also endoscopic decompression?
Yeah, of course, it's indicated.
And
If patient already blind, you have no risks during optical nerve decompression. He's
okay.
already blind. It's only chance.
I think that we have just time for one question and not more than that. And the question that is coming after the ethmoidal artery retraction, and the same attendee is asking, do you use nasal packing, or what do you use for it?
No, it's better to remove nasal packing if you got such a complication and decompress orbita, lateral cantotomy. It helps.
Exactly. I do agree with that. To
This
living.
complication was first described by Walter Messelklinger. I remember from these very first books, he explained this complication.
Yes,
It's also possible. It was possible in his opinion also during DCR procedure.
I was.
But now we are experienced enough to prevent such complication. When we asked Heinz Stamberger about anterior artery, he said, you don't need to see it when operating ethmoids. That was answer of expert number one for me.
Well, unfortunately, we don't have much time to go ahead with questions. There are so many, and I couldn't be able to ask all the questions that are coming from the Facebook channel and from YouTube. However, if you want, if you let me, we always letting have our attendees emails or contacts from the guest speakers so they could interact with you for any other questions or so ever. So if you could permit me, we will let them have any of your contacts so they will get you in contact for further questions. Is it okay for you?
Absolutely.
Thank you so much. So thank you, Professor Karpischenko, for being with us today. The orbital complication, it's a very important topic because as firstly said, those complications should be pointed out as soon as possible, because as much time is passing, the worst scenario will come. We're dealing with the orbit. That means visions. That means one of the most important necessity of our patients. So also you pointed out the importance of avoiding mistakes like opening sinuses incorrectly if we can do it in a proper way and in an easy way. Like, for example, I do agree with the pre-lacrimal approach for simple cases. Otherwise, we cannot deal with foreign body. For example, what you presented was the presence of an implant inside of the floor of the sinuses, and sometimes to reach in there, you have to use angle scope, you have to use angled instruments. So why not using a pre-lacrimal approach, which is very, very important. As you said, avoiding unnecessary approaches internally if we can deal it from outside. Sometimes we have to take care of external approaches. And as you said, the importance of avoiding unnecessary procedure is mandatory because we are dealing for simple procedure. This is a functional endoscopic sinus surgery. This is not a salvage procedure. So the first thing is that we're dealing with polyps or inflammatory processes. So we have to avoid those complications. So thank you for being with us. And I remember once again the further appointments for the future, not in short term, but in long term. So if we have to think about it, just pinpoint. If we can, I hope we will pray for the ERS meetings. Otherwise, I will suggest everyone to attend the meeting in Russia next year, 2021. We will pray. We will hope that whole situation will be solved. How's the situation in Russia? Is it manageable?
Yeah, for sure.
Thank you. I pray.
Working hardly, and we are nicely informed also by you how to do it better.
Thank you so much. We in Italy, we are facing this huge problem, so it's important to cooperate and to collaborate with our friends and colleagues from all around the world. Only united we can face this. Thank you, Professor Karpischenko, for being with us. It's those beautiful images, I think, that are important to let the people know what is going to happen next year. Thank you so much for being with us, and I'll see you hopefully very, very soon. Goodbye.
Yeah. Be safe.
Thank you.
Bye.